Assalamualaikum. I am Dr. Siraz Ali, a resident urology. I am presenter of today's lecture, and my moderator is Dr. Mohsen Mustafa. Our today's topic is muscle-invasive bladder cancer. Objectives: it includes staging, a radical cystectomy, bladder-sparing strategies, and key points. In staging, we have already studied in our previous lectures that up to the T1 disease. Today's our lecture is muscle-invasive bladder carcinoma, which starts from T2 disease. As we see in this diagram, this is the detrusor muscle. It is its superficial layer, and this is its deep layer. So in T2A, it involves the superficial layer, and in T2B, it involves the deep layer. In T3, it involves perivesical. It has a perivesical involvement. If it's macroscopically, it is T3A. When it is macroscopically or beyond the perivesical area, this is T3B. In T4, it involves prostate and seminal vesicle in male. In female, it involves uterus, as well pelvic and abdominal wall. When T4A is when it involves prostate, and in T4B when it involves pelvic wall or abdominal wall. This is the TNM classification. Tumor size is already we have mentioned. So we will discuss on lymph nodes. N stands for regional lymph nodes, N0 when there is no regional lymph node, N1 metastasis in single lymph node in the true pelvis, that is hypogastric, obturator, external iliac or presacral. N2 it involves metastasis in multiple lymph nodes in the true pelvis, and N3 metastasis in common iliac lymph nodes. And M stands for distant metastasis. M0 means no distant metastasis, M1A no regional lymph nodes, and M1B. M1A includes non-regional lymph nodes, and M1B other distant lymph nodes. So urethral carcinoma is the most common bladder cancer histologically. It's 90% diagnosed in the US, followed by squamous, that is 2 to 5%, and adenocarcinoma 2%, and other rare 1%. These are the recommendations for staging, radiological staging of the tumor. In patients with confirmed muscle-invasive bladder cancer, use CT chest, abdomen, pelvis with contrast, including some form of CT urography with designated phases for optimal urethral evaluation. MRI can be used where CT is contraindicated, or there is a for contrast contraindication are dose radiations. Use CT or magnetic MRI for staging locally advanced or metastatic disease in patients whom radical treatment is considered. Use CT to diagnose pulmonary mets. CT and MRI are generally equivalent for diagnosing local disease and distant mets in abdomen. This is the flow chart. Diagnosis, it's mainly on cystoscopy and tumor resection per urethral. That is gold standard for diagnosis. Evaluation of urethra and CT imaging of abdomen, chest, and upper urinary tract. MR can be used for local staging. For finding when it is T2 to T4 with no regional or distant metastasis. Neoadjuvant therapy, chemotherapy recommended in cisplatin-fit patients, 5 to 8% survival benefits. Radiotherapy is not recommended. Immunotherapy is experimental only in clinical trials. Radical cystectomy, no general aspects of surgery, preparation, surgical techniques, integrated node dissection, urinary diversion, timing of surgery. A higher load case load improves outcome. For adjuvant therapy, considered in high-risk patients only if no neoadjuvant therapy was given. Neoadjuvant therapy. Neoadjuvant cisplatin-containing combination therapy. It improves overall survival 5 to 8% at 5 years, irrespective of type of designated treatment used. Patients may respond to neoadjuvant chemotherapy and have a favorable pathological response as determined mainly by achieving YPTO less than or equal to YPT1 or YPNO and negative surgical margins. Response after 2 cycles of treatment is related to outcome. In the future, genetic markers in personalized medicine setting might facilitate the selection of patients for neoadjuvant chemotherapy and differentiate responders from non-responders. The checkpoint inhibitors have shown significant benefit in patients with unresectable and metastatic bladder cancer in the salvage setting and in platinum-ineligible patients as first-line treatment, but data are still immature. These are the recommendations for chemotherapy. After neoadjuvant chemotherapy, for T2 to T4A N0M0 bladder cancer, in this case, always use cisplatin-based combination therapy. Do not offer neoadjuvant to patients who are ineligible for cisplatin-based chemotherapy. Only offer neoadjuvant immunotherapy to patients with a clinical trial setting. Do not offer preoperative radiotherapy for operable muscle-invasive bladder cancer, since it will only result in downstaging but will not improve survival. Do not offer preoperative radiotherapy when subsequent radical cystectomy with urinary diversion is planned. Consider offer adjuvant radiation in addition to chemotherapy following radical cystectomy based on pathological risk or positive nodes or margins. Surgical management of bladder cancer. It is a tumor resection per urethral radical cystectomy. It can be open, robotic, or laparoscopic, and partial cystectomy. Radical cystectomy. The history of transurethral resection and surgical removal of the bladder dates to the 18th century. Bladder of Germany is credited with performing the first cystectomy in 1887 in a patient with an advanced tumor of bladder. The first modern technique was for cystectomy appeared in 1956 from Pequin and Marshall. In their early description, radical cystectomy in men began with the perineal exploration and dissection of the rectum from the bladder and prostate under direct visualization. In addition, they favored cutaneous ureterostomies for diversion. Radical cystectomy indications. In non-muscle invasive, these include very high risk non-muscle invasive bladder cancer, extensive papillary disease that cannot be controlled with TURBT and intravesical chemotherapy or immunotherapy, BCG relapsing, refractory and unresponsive, T1G3 with diverticulum, or diffuse carcinoma in situ. Indications for muscle invasive, it includes from T2 to T4A and not M0. Others include non-urethral carcinoma like squamous adenocarcinoma. In salvage cystectomy, non-responder to conservative therapy, recurrence after bladder sparing treatments, and palliative intervention, which includes fistula, pain, recurrent uncontrolled macrohematuria. Radical cystectomy preparation. In advance of surgery and surgical therapy for bladder cancer, appropriate preoperative staging and medical evaluation should be performed. After confirmation, before surgery of localized disease, patients should undergo routine medical evaluation to maximize the health status. Comorbidities such as coronary artery disease, smoking related lung disease, and peripheral vascular disease will commonly be encountered. Patients should be made aware of the possibility of anilial conjugate urinary diversion even in the case of planned continent diversion. Consent and counseling. Patient is explained about his disease and the diagnosis for muscle-invasive bladder carcinoma, the need for surgery, the prognosis, that is 5-year survival, 50 to 60%, organs removed, urinary bladder, distal end of ureter, and lymph nodes for both gender. And in male, it includes prostate and seminal vesicles. In female, it includes uterus, cervix, round ligament, ovaries, and anterior vaginal wall. Patient is explained about urinary diversion, that is continent or incontinent, and its complications. And vas deferens ligation and erectile dysfunction. General complications, it include infection, bleeding, collateral trauma like trauma to rectum, and gut diversion. Main steps, it includes preoperative preparation, positioning of patient, incision, abdominal exploration, bowel mobilization, ureteral dissection, pelvic lymphadenectomy, ligation of lateral vesicular pedicle, ligation of posterior vesicular pedicle, anterior apical dissection. Positioning. Male patient should be placed in supine with flexion point of the table at the level of anterior superior iliac spine. Flexion to the 15 degree is usually adequate and can be lessened as necessary if there is a history of spinal fusion or a lumbar injury.
In women, why this position is important? Like, what is the significance of this extended position?
इजी होगा सर्जरी अप्रोच के लिए। दूसरी ये कि गट है जो अपवर्ड वाले हैं वो मूव करेंगे अपवर्ड थोड़ा फील्ड के लिए।
Even have a good access to the pelvic side and to remove the to clear the field from the gut.
Yes.
In women, low lithotomy position with aid of stirrups or the use of aspirator bars provide access to vagina. The operative field should be inclusive of the abdomen from the level of xiphoid to the upper portion of the thighs, and the genital organs including vagina in women, and the perineum should be prepared as well. Surgical technique. A lower midline incision is made sharply extended superiorly from umbilicus to the level of the pubic symphysis distally. Upward retraction of the umbilicus toward the ceiling aids in the identification of the linea alba. After the midline is identified, the fascia is divided and the space of radius is entered. The blunt dissection is performed to release the bladder from pelvic side wall attachments bilaterally. This is carried in a cephalad direction to the level of vas deferens in man and round ligament in female. At this point, peritoneotomy is made lateral to either medial umbilical ligament, and the urethra is controlled and divided. The peritoneum is incised laterally to the medial umbilical ligament, bilaterally to the level of internal inguinal rings, at which point the vas differentia in man and the round ligament in women will be identified and are divided. And the bowel mobilization. And the bowel mobilization to achieve adequate exposure of the great vessels and the ureters. On the right side, the white line of told is incised and carried around the cecum, where then the posterior peritoneum is incised to allow the mobilization of the root of the small bowel mesentery. On the left side, the white line of told is likewise incised, and window is created below the sigmoid colon mesentery to communicate with the right-sided posterior peritoneotomy. This space will later be used to transpose the left ureter to the right lower quadrant for urinary diversion. Add a retractor such as Bookwalter, exposure is maximized and the gut is retracted cephalad. Communication with anesthesiologist is necessary at this point as it may compress the inferior vena cava. A moistened laparotomy pad or pads should be placed behind the retractor blades to protect the abdominal contents. After adequate exposure is achieved, the bilateral ureters are dissected free from their attachments, beginning few centimeters above where they cross the iliac arteries to the level of the detrusor hiatus. The obliterated umbilical artery should be ligated and divided before completing the ureteral dissection. This adds in maximum ureter length. The distal ureter margin sent for frozen section analysis to evaluate for the presence of urethral carcinoma. Pelvic lymphadenectomy. The pelvic lymphadenectomy can be performed at anatomic boundaries of a standard template dissection. Consists of genitofemoral nerve laterally, the internal iliac artery medially, Cooper's ligament inferiorly, and point at which the ureter crosses the common iliac artery superiorly. In cases of advanced disease, an extended dissection inclusive of the entire common iliac lymph node packet and presacral lymph node packet can be obtained. In patients in whom at least 10 lymph nodes were removed, 5-year survival improved from 44 to 61%. This is the diagrammatical presentation of lymph nodes. This is the limited pelvic lymph node dissection that is below on the level of bifurcation of common iliac arteries, and this is the standard pelvic lymph node dissection that is up to the level of bifurcation, and this is extended that include the level of abdominal
Above the level of common iliac.
And super extended that include the inferior mesenteric or para-aortic lymph node.
Up to the inferior mesenteric artery. Anybody, is there any importance of these lymph node dissections in terms of disease-free survival, and does it have any prognostic or therapeutic value?
जितने ज्यादा रिमूव करेंगे तो वो सर्वाइवल रेट उनका उतना अच्छा होता जाएगा. 14% बेहतर होगी सर्वाइवल में. तो जितने ज्यादा लिम्फ नोड रिमूव करते जाएंगे तो सर्वाइवल इतनी अच्छी होती जाएगी इसकी.
It is well established fact that it is always advantageous to have lymph node dissection, and the number of lymph nodes taken has got its own importance. Usually they recommend at least more than 10, and some data says that they give a good prognostic as well as therapeutic. It has got importance on both.
At the completion of the pelvic lymphadenectomy, it aids in the exposure and identification of the vascular pedicle to the bladder. Control of the main branches to the bladder, including the superior, middle, and inferior vesical arteries, can be achieved with the aid of a vascular stapler, surgical clips, or vascular sealing instruments.
Dr. Shiraz?
Yes, sir.
Is there certain indication for different level of lymph node dissection, or it is just surgeon's choice whether he has to go for the limited dissection or extended? Can you go back to the previous slide, please? So here you have shown 4 schematic diagrams of 4 types of lymph node dissection: limited, standard, extended, and super extended. So the question is very simple: whether surgeon has to decide, it is surgeon's choice, or there is any certain indication in scenarios where you have to go for the super extended lymphadenectomy, and in some scenario you can just stick to the limited pelvic node dissection.
Sir, if there is any visible lymph node, then that the extended approach is preferable, and to my knowledge, and you may add if there is a specific indication to these different approaches.
Yes, exactly. You have to visually examine the pelvic area, and if you happen to find out any palpable lymph node, then you have to switch from limited to extended or maybe super extended. So it is not just there are four types of dissection, and surgeon has to decide what type. If you are unable to find any palpable lymph node, then you have to go for the at least limited pelvic lymph node dissection. So minimum criteria is limited, but according to the case-to-case variation and according to the findings during surgery, you can then tailor-made that approach.
Sorry, but the main question is why you are going towards extended and super extended pelvic lymph node dissection. What are you looking for? Naveed?
Sir, currently there have been some research work and experimental work going on to find out the sentinel lymph nodes. So you never know which lymph node is the culprit, where it is draining most. So the basic idea, as far as I understand, is to go and include that sentinel lymph node along with those bunch of lymph nodes so that you can take out the disease in toto. And this should leave no doubt in your mind that there should be some residual disease back in the patient body.
Yeah, this is correct. So this concept of sentinel lymph node is very important. It is very important in cases of breast cancer. It is also very important in cases of bladder tumor as well as in prostate cancer. And these days, there are many research groups who are actually in the process of evaluating and using researching different kind of agents that can give you a clue of which lymph node is a sentinel lymph node, which happens to drain the most of the disease from the bladder or prostate or from any organ which is under discussion or under consideration. So, for instance, if you are doing robotic surgery, particularly with the Da Vinci system, and you have got the availability of a special filter by which you can have a kind of an inclination or an indication if you inject a little bit of a dye which is known as indocyanine green, so that will be actually drained into the sentinel lymph node, and it will glow as compared to many other lymph aggregates which are along the chain. So it will glow more, and the more it glows, the more will be the chance of having the most of the disease drained by that kind of a lymph node, which we call sentinel lymph node. So indocyanine green is one important agent which is being used and is being extensively researched. But it has got its own follies. It has got its own flip side also. For instance, how much indocyanine green is to be injected, where it is to be injected, at which point in time during surgery it is to be injected. So people are not very much sure which is the actual protocol that everybody should follow. So the same happens with, for instance, other kind of agents which are radio labeled agents, and you can use, for instance, a drop-in probe, which is a gamma probe that can detect the sentinel lymph node again. So the extent to which the lymph node dissection is to be done is actually guided by still by your palpation if you happen to do it on an open platform. But if you are on a laparoscopic or a robotic platform, since the tactile sensation is replaced by your vision, so it will be the visual appreciation which gives you where your dissection should end. So this is the actual scenario at present.
After completion of pelvic lymphadenectomy, control of the main branches to bladder, including the superior, middle, and inferior vesical arteries, can be achieved with aid of vascular stapler, surgical clips, or vascular sealing instruments. Radical these steps were similar for both genders, and there's a slight difference in male and female gender. So we will talk about radical cystectomy in male. In male, after the anterior vascular pedicle blood supply is completely ligated, attention is turned to the posterior dissection. The rector cul-de-sac is identified, and the peritoneum is incised where it overlies the seminal vesicles. And the rectum is dissected free with either blunt dissection or sharp dissection with midline, and is carried to the level of prostate, at which point Genitofemoral fascia is encountered and incised. This is the diagrammatical representation. This is the prostate, this is bladder, and this is the cul-de-sac space, and this dotted line is Genitofemoral fascia that is incised here in this diagram. Now, after completion of posterior dissection, the urethra should be palpable, and at this point, attention can be turned to the anterior dissection. The endopelvic fascia overlying the elevator muscle is incised sharply, allowing for identification of the confluence between the urethra and the dorsal venous plexus. Ligation and division of the dorsal venous plexus allows for visualization of anterior urethra, which is then incised. Nerve sparing is the preferred choice in advanced disease and in patients with pre-existing erectile dysfunction. Radical cystectomy in female. Radical cystectomy in female includes total anterior pelvic extension, inclusive of the bladder, urethra, anterior vagina, uterus, and cervix. This allows for adequate section and is vital in the presence of positive examination under anesthesia, or if there is a concern for anterior vaginal wall invasion, CT4A disease. The initial steps for bowel mobilization, anterior bladder mobilization, and urethral dissection are the same in men and women, with exception of gonadal vessels. In females, the ovarian vessels should be identified during the bowel mobilization and ligated. Anterior pelvic exentation begins with the identification of posterior cervical fornix, and the vaginal cuff is incised at this point. After gaining entry into the vaginal canal, the surgeon easily can control lateral and posterior vascular pedicles to the bladder. Vascular stapler sealing devices or clips are applied, and the specimen can be dissected free, inclusive of the uterus, cervix, anterior vaginal cuff, and bladder. And the urethral meatus is then incised either antegrade from the pelvis or externally from vaginal intraosseous, and the specimen is removed. To complete the vaginal closure with 2-0 vicral sutures, often the posterior vaginal wall must be released from the rectum. The posterior vaginal flap is then closed to the corresponding mucosa of the intraosseous in a clump shell fashion to maintain vaginal girth at the cost of some vaginal length. The vaginal packing is placed in the dual purpose of distending the vagina and providing tamponade to any residual vaginal hemorrhage. This packing should be removed 2 days post-operatively. Recommendations for radical cystectomy and urinary diversion. Do not delay radical cystectomy for more than 3 months, as it increase the risk of progression and cancer-specific mortality unless the patient receives neoadjuvant chemotherapy. It has a strong strength. Perform at least 10 and preferably more than 20 radical cystectomies per hospital per year. Again, it has a strong strength. Before radical cystectomy, fully inform the patient about the benefits, potential risks of all possible alternatives. The final decision should be based on a balanced discussion between patient and the surgeon. Do not offer an orthotopic bladder substitute diversion to patients who have tumor in the urethra or at the level of urethral dissection. It has strong strength. Do not offer sexual preserving radical cystectomy to men as standard therapy for muscle-invasive bladder carcinoma. It has strong strength. After sexual preserving technique to men motivated to preserve their sexual function, since the majority will benefit. Select men for sexual preserving techniques based on organ-confined disease, absence of any kind of tumor at the level of prostate, prostatic urethra, or bladder neck. Strong. Do not offer pelvic organ preserving radical cystectomy to women as a standard therapy. It has strong strength. Offer sexual preserving techniques to women motivated to preserve their sexual function, since the majority will benefit having weak strength. Select women for sexual preserving techniques based on absence of tumor in the area to be preserved, to avoid positive soft tissue margins, absence of PT4 urothelial carcinoma. Strong. Preoperative bowel preparation is not mandatory. Fast-track measurements may reduce the time to bowel recovery. It is strong the same. Offer pharmacological prophylaxis such as low molecular weight heparin to radical cystectomy patients starting the first day post-surgery for a period of 4 weeks. Offer radical cystectomy to patients with T2 to T4A non-metastatic disease or high-risk non-muscle invasive bladder cancer. It has strong strength. Perform lymph node dissection as an integral part of radical cystectomy. Do not preserve the urethra if margins are positive. Recommendations for laparoscopic or robot-assisted laparoscopic cystectomy. Inform the patient of the advantages and disadvantages of open and robot-assisted radical cystectomy to allow selection of the proper procedure. Select experienced centers, not specific techniques, both for robot-assisted and open radical cystectomy. Both have strong strength. Now the partial cystectomy. Partial cystectomy with consideration for the bladder sparing surgery in the setting of muscle-invasive urethral carcinoma requires proper patient selection. In a population-based matched cohort study examining partial versus radical cystectomy, when matched for surgical quality, number of lymph nodes removed, and clinico-pathological features, partial cystectomy was equivalent in terms of overall and cancer-specific survival. In patients with organ-confined disease, 5-year survival is 60%, whereas it is only 7% for extravesical disease. Indications for partial cystectomy. It includes solitary lesions, location preferably at bladder dome, size less than 2 cm, complete excision possible with 2 cm tumor-free margins, adequate bladder capacity, no carcinoma in situ, and patient reliable for follow-up. In the selected patients who are candidates for partial cystectomy, preoperative preparation include counseling regarding the possibility of radical cystectomy and the discussion of urinary diversion. Partial surgical removal includes pelvic lymphadenectomy as well as anterior bladder mobilization. Cystectomy is performed in an area away from the tumor. The tumor is then excised, including the underlying bladder wall and prevesical fat with a mucosal margin of 1 to 2 cm and confirmation of resection adequacy with frozen section analysis. If necessary, the uretral orifices or intramural ureter can be excised and reimplantation performed. After excision of the tumor, the cystectomy is closed with 2 vacral sutures in 2 or 3 layers, and insertion of fluid through Foley catheter is performed to ensure a watertight closure. Copious warm water irrigation of the surgical field is performed to minimize the possibility of pelvic seedling. A closed section drain should be placed and the cystostomy closure integrated with cystogram on postoperative day 7 before the removal of Foley's catheter. Bladder augmentation with the use of an intestinal segment can be performed if bladder capacity is significantly reduced. Recommendations for bladder sparing treatments for localized disease. Do not offer urethral resection of bladder tumor alone as a curative treatment option, as most patients will not benefit.
शिरा अच्छा ब्लेडर स्पेयरिंग ट्रीटमेंट ऑप्शंस कौन कौन से हैं हमारे पास अवेलेबल होते हैं? एक तो पार्शियल सिस्टेक्टमी इन्होंने बताया है, दूसरे कोई हैं ऑप्शंस? ट्राइमोडल थेरेपी, इसमें क्या होता है? ठीक है, और प्राइमोडैलिटी की सेटिंग में होती है यूजुअली रेडियोथेरेपी, एक्सटर्नल बीम रेडियोथेरेपी और सिस्टमिक कीमोथेरेपी अलॉन्ग विद सपोर्टिव केयर जो सर्जिकली अनफिट पेशेंट्स हों, कोमॉप्स के साथ हों.
Do not offer radiotherapy alone as a primary therapy for localized bladder cancer. Strong stenting. Do not offer chemotherapy alone as primary therapy for localized bladder cancer. Offer surgical intervention or trimodality bladder preserving treatments to appropriate candidate as a primary curative therapeutic approaches, since they are more effective than radiotherapy alone. Offer trimodality therapy as an alternative to selected, well-informed and compliant patients, especially for whom radical cystectomy is not an option or not acceptable. Key points. So optimal treatment of muscle-invasive bladder cancer requires a multidisciplinary approach incorporating urological oncologist, medical oncologists, radiation oncologists. Current clinical staging modalities lack the sensitivity and specificity to predict accurately the final disease stage, which is currently a major limitation to pre-treatment decision making. The gold standard therapy for organ confined muscle-invasive bladder carcinoma is radical cystectomy with neoadjuvant cisplatin-based chemotherapy. Bladder preservation with chemoradiation therapy has become an increasingly popular option in the muscle-invasive setting and has demonstrated outcomes comparable to those of radical cystectomy in highly selected patients. Despite aggressive surgical therapy, approximately 50% of cystectomy patients will ultimately die of disease. Meta-analysis for systemic cisplatin-based neoadjuvant chemotherapy trials have been demonstrated a modest but statistical significant survival advantage. The evidence for adjuvant chemotherapy is less robust, secondary to inadequately powered trials and methodological flaws. Initial response rates with cisplatin-based chemotherapy in the metastatic setting are favorable. However, durable responses are rare, and outcome for this patient population are dismal. Multiple new second-line chemotherapy trials have been completed or are underway with varying response rates. Newer biological agents hold promise. However, evidence is currently lacking and more studies are warranted.